and welcome to Virtual Abilities 2024 International Disability Rights Affirmation Conference. I am Valencia Skydancer. I have post-traumatic stress disorder and I use a rollator due to neuropathy in my legs. I love to explore and play the different games in Second Life. I own a small cafe. Today I'd like to introduce Muhammad Mamdani and Amol Verma. Dr. Mamdani is Vice President of Data Science and Advanced Analytics at Unity Health Toronto and Director of the University of Toronto Telemetry Faculty of Medicine Center for Artificial Intelligence, Education, and Research in Medicine. Dr. Verma is an Associate Professor in General Internal Medicine at St. Michael's Hospital and the University of Toronto, and the Telemetry Professor of AI Research and Education in Medicine at the University of Toronto. Today they are presenting information regarding the promise and pitfalls of AI in medicine. This presentation will provide a basic overview of artificial intelligence, AI, in medicine and its applications using real-world examples. It will also highlight potential challenges with developing and deploying AI solutions in realizing societal benefits and minimizing risk for potential harm. Please hold all questions till the end of the presentation. Gentlemen, the floor is yours.
Thank you so much for having us. It's really a pleasure to join you here in Second Life. And apologies up front for any lack of adeptness on our part in navigating this really exciting and dynamic interface. So we're pleased to share with you some of our work focused on artificial intelligence in medicine. There are so many and a growing number of applications of AI, and I'm really pleased that Mohammed is here. He'll speak from a little bit of a broader perspective on various applications. And what I really want to do is speak from a bit of a narrower focus on one specific project that we've implemented in the area of predictive analytics. So that's the idea of using AI to predict something that may happen in the future. And in particular, if we are trying to predict events that are undesirable, like patients getting sicker, then perhaps that early warning or early notice can help us prevent that thing from happening. So I want to speak a little bit about predictive analytics. So we know from a large body of research that the number one root cause of patients deteriorating in hospital or ending up in an intensive care unit unexpectedly is when their doctors and nurses fail to recognize that they are getting sicker. We fail to recognize their clinical deterioration, and we can't rescue the patient, a failure to rescue. So this creates potentially an exciting opportunity for using artificial intelligence to monitor the physical status of patients while they're in a hospital and give us an early warning before patients start to get sicker. We know that about 5 to 10% of hospital patients become so sick in hospital that they need intensive care, they need life-supporting treatments, or they might even die in hospital. So the question is, can we predict in advance who those patients are and try to prevent that from happening? So we developed a tool called ChartWatch. It's an AI tool that takes about 100 different pieces of information that are routinely entered into the hospital's electronic medical record. So when a patient is treated in hospital, the nurses are measuring their blood pressure and their heart rate and putting that information into the computer. The doctors are ordering laboratory tests, and the results end up in the computer. So our question was, could we use all that information that's already in the computer to predict which patients might deteriorate, might end up going into the ICU, or even dying in hospital, and provide an early warning signal to doctors and nurses so they can intervene. And specifically, to intervene, they would be trying to reduce mortality, reduce death, prevent those deaths from happening. But also, when that death cannot be avoided, we know that some deaths cannot be avoided, then we would also want to be able to improve end-of-life care, get early access. We know that even though we can't always prevent death, we can always ease suffering with compassionate, comprehensive care. So improve access to early end-of-life care. Can we improve the way that we communicate? If we were to know that a patient was high risk, could we tell their family? Could we tell the patient that we're worried about them in advance so they can prepare? And can we improve the way our teams talk to each other, the nurses and doctors and others talk to each other? So we developed this tool. In addition to this prediction tool that uses all that information in the hospital's computer systems, we also have a comprehensive care pathway. So when the computer identifies a patient as being high risk, it sends an alert to the clinical team, and then we provided a designed care pathway for these high-risk patients. And this pathway was designed with the clinicians, with the nurses and doctors, with input from patients and families and hospital administrators. And it tells us what to do for high-risk patients so that we know what to do for alerts. And so that's really important, that this quote-unquote AI tool includes an aspect of AI, but it also includes a comprehensive human part of care too, which is a care pathway that what should our clinicians, what should our clinical teams do in response to these AI notifications. So it's not an autonomous tool, it's AI supporting humans in doing their work, supporting the clinicians in doing their expert work. So we developed all of this, and we spent about 3 years rigorously developing these tools, developing this care pathway, testing it out through a variety of different studies over a 3-year period. And then we deployed the tool in October of 2020. And here's what we found. So before we implemented the tool on one unit in our hospital. That's this GIM unit. GIM stands for General Internal Medicine. It's the general adult medical ward where patients with conditions like pneumonia, lung disease, heart disease, kidney disease end up. And it's the largest single unit in our hospital. What you can see on the slide here is a y-axis for something called non-palliative death. That means deaths that occur without palliative care. If you recall from our goals, we want to prevent deaths and we want to deliver early palliative end-of-life care for deaths we can't prevent. So the deaths that occur without palliative care are the patients that we could not intervene on, the patients that died unexpectedly. There are other subspecialty units on our hospital. So these are the kidney unit, the heart unit, and the lung specialty units, which are similar to the general medical unit, but which did not receive ChartWatch. It didn't receive the intervention. So in the 4 years prior to deployment, you can see that the rates of non-palliative death on our general medicine unit and subspecialty units were very similar. After we deployed ChartWatch, you can see a big difference. So the unit that received ChartWatch had a 3% reduction overall and about a 30% improvement in the number of these non-palliative deaths, whereas the units that did not receive this intervention saw essentially no change. And so this gives us a lot of early promising signal that this is a very effective intervention. What you can also see is that when we published this study, there was a lot of attention in the media, in the Canadian media especially. And that was really exciting to us. But what really matters more than that is the actual patient stories, how this actually can improve individual people's lives. So here's a real world story. So it was 11 o'clock one night, and a ChartWatch alert went off for the patient. She went, so the resident doctor went and reviewed the chart and went to see the patient as per the recommended protocol. The patient was stable, and actually the doctor couldn't figure out what was wrong with the patient. So they went back to doing their work. But about 2 hours later, they got a call from the ward nurse saying the patient was suddenly in severe respiratory distress, was having a lot of difficulty breathing. They went to see the patient, and because they had already done that initial assessment, they didn't need 10 or 20 minutes to figure out what was happening with the patient. Within a minute, they could call the intensive care unit team. They could get the patient in a much more monitored, safe setting, and the patient didn't have a code blue arrest on the floor, which really was because this ChartWatch signal gave them that early warning notice. So this is how ChartWatch is really making a difference. But one of the challenges with what are the challenges? This is, an AI solution that was deployed in one unit of one hospital. How can we get these technologies to work more broadly? And so I'd like to conclude with a few series of thoughts about the challenges of AI. One really important challenge is that AI solutions work best in the data where they were trained. So if you develop an AI tool in 2 hospitals in the southern United States, it may not work well in other parts of the world. And we saw that to be the case. This was an AI algorithm developed by a company called Epic. It was trained in 3 hospitals, but then when it was deployed in another 2 hospitals in Michigan, it worked very poorly. It was 90% of the alarms were false. It missed 2/3 of the high-risk infectious cases that it was designed to create. So we need to be careful when we're taking AI technologies from one setting and using them in another. Another reason that AI technologies can be difficult or problematic is they can hold biases in them. So this is a famous example from a large American insurance provider where they developed a model that predicted which patients would have the highest healthcare costs so that they could then give more services to those patients with the belief that people with high healthcare costs might have high healthcare needs, and so maybe we can help those people. One of the problems, though, was that historically in this network, Black people were underserved. And so they had lower healthcare costs. So when they tried to predict based on healthcare costs, the algorithm directed resources away from Black people. And that's a really bad problem, obviously. And so it's really important when we're considering AI algorithms that we think about the potential biases that they could bring into our society and that we are very careful before we deploy them. I'm going to just conclude with one set of thoughts. So I'm going to click through this set of slides. To take an AI solution from solution design all the way through to deployment, evaluation, and maintenance, so get it into use, into clinical practice, it takes a lot of expertise and effort. And very few projects actually make their way through, especially projects that start with rigorous research. On the other hand, there are a lot of projects and products that are being sold by companies that have not been developed so rigorously. And so we need to figure out a way to get more rigorously developed solutions into use and to more rigorously test the solutions that are being sold. And I believe that the way to do that is to create networks. And this is the work that our group is doing now, is to create an AI network where you need to pull together data, because AI algorithms train off data, computing infrastructure to actually develop the algorithms, and then the people that have the know-how to actually develop the data and algorithms. And those people, I use that term broadly. It includes patients and their caregivers who understand the experience of having illness and who actually may know more about their illness than care providers in some cases, who have the expertise about how these tools can be useful. But it also includes computer scientists, it includes clinicians, it includes people with knowledge about law and ethics. So we need to pull together a network of all of these people and then connect it to healthcare providers so that these networks don't live just in academic, well-resourced, large hospitals, but also work more broadly across the healthcare system. And so those are the very kind of networks that our research team is trying to build right now. And the project that we're doing it with is an initiative called Gemini. So Gemini brings together data now from 40 hospitals across Ontario, puts it together into a state-of-the-art computing environment, and makes it available to a network of doctors, of nurses, of researchers, and students, so that we can try to build these solutions so that they're more likely to work for everyone. This is my last slide. I really do think that it is the challenge of our generation to integrate these new computing technologies in medicine to improve the quality of care that we deliver, and importantly, to improve the humanity of care that we deliver. And so really grateful for the invitation to be here and happy to take any questions. I do unfortunately have to leave at 2 o'clock, but I'll make sure that my email is circulated and I'll put it in the chat. I'd also welcome any engagement after today. Thank you so much for having me. Over to you, Mohammed.
Thanks, Amal. Fantastic presentation as always. I'm going to go through my slides. I'll try and be fairly quick to leave some time for questions. Actually, I think that's my last slide, so I'm going to, there we go. All right, fantastic. Okay, here we are. As Amal had said, there's a lot of growing interest in artificial intelligence in healthcare. If we look at just the activity with respect to academic productivity and publications in the research space, about 15 years ago, there were maybe a couple hundred papers that were published every year. Now there's tens of thousands of papers that are published every year. And one of the reasons why is because there are increasing applications. People are seeing increasing applications of AI in healthcare. There's also translation into actual things you can buy. The US FDA, as of August of this year, had approved 950 AI or machine learning enabled devices. That's grown exponentially. I'm sure it's well over 1,000 now, and there will continue to be more and more devices in healthcare that you can buy that actually have machine learning or AI in them. I don't know if people have heard of KardioMobile. It's something you can buy on Amazon. Basically, you plug it into your phone, and it's a portable electrocardiogram, which basically can detect heart abnormalities using AI. The other reason why we're seeing such a huge spike in AI is because we're also seeing a lot of money being poured into this. So if we take a look at the health AI market size, it's increased from $20 billion just last year to it's expected to grow to over $500 billion in less than 10 years. So a lot of interest in this space from a financial perspective as well, and that unfortunately drives, or fortunately drives, a lot of development. Amal and I are from Unity Health Toronto, which is basically a composition of 3 sites in Toronto, 3 healthcare organizations, St. Joseph, St. Michael's, and Providence. And together we form Unity with a lot of people, a lot of data. The unique thing about our organization in Toronto is we're the only healthcare organization in Canada, and I believe, as far as I know, the only one, but maybe a few in the world, that has declared AI as a core strategic pillar. We have 9 strategic pillars. 3 of them are core strategic pillars. One of them is AI. So from the board of directors to the CEO throughout the entire organization, AI is a big part of what we do, which means we put resources into it. So we have a team of about 30 people who work with incredible clinicians like Amal to develop solutions that are really going to make a difference to patients. We've deployed over 50 AI solutions into clinical practice, and that's, as far as I know, more than any other hospital in the world right now. We are fairly aggressive in this space. But a lot of people are really paying attention to this. So if we look globally and internationally, we see things like Taiwan, for example. In Taiwan, I think this is supposed to open next year, is an AI hospital of the future, where basically the hospital is really built for AI, which I think is going to be super exciting for people, for practitioners, for patients, for everybody, really. If we look at India, they've been fairly aggressive in this space as well, with a lot of AI adoption. And some will argue that in China, India, there's maybe a little bit less oversight. I would say they're probably just more progressive and aggressive in this space than we are. If we look at countries like Singapore, they're actively deploying AI into their public health systems, which I think is exciting as well. That doesn't come with caveats, though, right? Without caveats, sorry. As Amol suggested, algorithms, when used properly, can really be impactful and really help people. But if they're not used properly, I think it can actually harm society. So we have to be really, really careful. And a lot of this is going to be about including people who should be included. And that actually, I'm going to go now to inclusion of people with disabilities. There have been several groups that have written about this, including the Harvard Gazette, around why our AI fairness conversations have to include disabled people. There's stuff that's been written in the MIT Tech Review that AI has a tremendous potential for people with disabilities. There are actual solutions out there now. For example, this thing called VoiceIt that is actually available for purchase, where it's an standalone web app that supports communication with people and with technology around people who may not be able to verbalize as well as they could, or are trying to verbalize. This actually helps translate that into understandable, recognizable speech, which I think could be quite effective for a lot of people. I'm sure a lot of people have heard about Neuralink, where basically they insert a chip inside a person's brain, and especially for those who have paraplegic, quadriplegic, they're able to actually use the brain to actually control what's on a computer, for example, just by thought, which again I think is going to be super exciting. And they have actually tested or have started testing this in humans. To move it even one step forward, are things like this thing, where basically they're looking at exoskeleton systems, where they actually attach things to humans, but with AI systems that will actually measure things like a patient's heart rate, their cognitive function, their muscular function, and they'll actually then what's going on in the brain, translate that into movements into this exoskeleton system, so people can actually move just by thinking. All that stuff is in progress right now. I'm sure it's not perfect, but this is where things are going, where I think give it a little bit of time and we'll start to see some really promising technologies that are going to help society at large and help to bridge that connection between humans and machines to really advance care for everybody. So I'll end there and leave time for questions. Thank you. Any questions?
Okay, Gento asks, might your work be even more important for small rural hospitals than for larger human ones, urban ones?
Sure. Maybe I can start and then hand it over to Mo. Yeah, I think so. We're very fortunate to be in a large academic teaching hospital with stellar clinicians, with specialists that a lot of smaller hospitals don't have, especially in rural areas. I'll give you an example. We have an algorithm right now that detects brain bleeds, and it also identifies patients who need immediate neurosurgical intervention. But if you put that in an academic hospital where we actually have neurosurgeons, we have 24/7 neuroradiologist coverage, the benefit is there for sure. We've seen the benefits, but it's going to be far more beneficial in a rural hospital that doesn't have neurosurgeons or neuroradiological services. So we're actually talking with the province of Ontario now around how we can actually scale this provincially so that all hospitals can benefit from these technologies, especially those who don't have the resources that larger hospitals do. Well, any thoughts at your end?
Yeah, I was. I think it's a. Thanks for the great question, Gentle. And I agree with everything Mohammed said. I do think that um, these kinds of technologies could be even more helpful in lower resource settings, but with the caveat that I think they need to be designed specifically for that purpose. So if we were to design a tool just based on data from large urban hospitals or with the skill sets and the workflow of large urban hospitals in mind, then I'm not sure these tools will easily translate to other settings. And so I think that this is where, when I spoke about trying to build networks, it's really important that those networks include smaller rural facilities where there are two things. One, deep knowledge about the local needs so that they can drive what questions are being asked or what kinds of solutions are being designed. And two, expertise about what is available and how a tool could work in that setting, so that we're not making assumptions. And I think if we do that, then yes, I think we have the chance to really create exciting technologies that can have a lot of impact. Thanks, Gentle. Absolutely. I think using AI as a tool to improve accessibility to services which are hard to get to is really an exciting opportunity for sure. Does anyone else have any other questions?
I think Dr. Verma may have a question for the audience. Oh, there's Warthog's question.
What else? Where do you think personal data should reside? Patient, doctor?
Yeah, thanks. I think it's a really important question, and I can maybe go first and then hand it over to Mohammed to add his thoughts. I think that wherever patient data resides, and the truth is, patient data or personal data now lives in many places. And I think the most important thing is transparency around where are those data being held and what protections are being put in place to ensure privacy, most importantly. And then, what are these data being used for? And I think the decisions around what healthcare data can be used for should be social decisions, right? That you need a sort of social contract. You need to have trust and the ability to think about how those data are being used, and so I really think that's important. And that kind of transparency should not be embedded in a multi-page long user agreement that we just scroll to the bottom of and click, right? I think we need to have ways of making it more clear to people how their data are being used and stored. And I know our hospital has tried to be very thoughtful about it. So maybe I'll turn it over to Mohammed for that. And I'll just say, I do have to run, but thank you so much for letting me be a part of this conference and this community. And to Gentle's comment there, our research program does seek the opinion and participation and partnership of people with lived experiences of various health conditions and including disabilities. And so I may reach back out to this community through Gentle to invite your participation in some of our research going forward. Thank you so much for having me here. So I'll hand it over to Mohammed, and thank you very much.
Thank you, Mo. Yeah, I'll just comment very briefly. I agree completely with Mo's comments. I do think, first and foremost, patients own their data, right? It is your right to your data. Healthcare organizations have the privilege of being custodians of that data with your permissions, and have the responsibility of safeguarding that data. So I do think there is an somewhat understood social contract that maybe needs to be a bit better understood. But that would be my view in terms of patients come first, as they should. And unfortunately, I have to leave as well. But it's been so terrific to be here and to be part of this experience. It's the first virtual conference that I think Mo and I have done, and it's really been fun. So congratulations to everyone who set up this conference. It's so exciting to see, and I really hope that this continues in full force. It's just amazing. Thank you.
Thank you both, and please remember to click the big green box in the center on the top of your controller. Thank you.
Thank you.